Hi, everybody. Welcome back to another of the lectures for treating individuals with special healthcare needs through the Rhode Island Department of Health. Thank you for being here again. So, today we're talking about medical immobilization and protective stabilization. And one of the questions you should be asking in your evaluation of the patient, which we previously discussed doing prior to the patient's arrival, is what is their history of receiving immobilization? Use of nitrous oxide, use of stabilization, limiting their movements. Do they already have a history of in-office sedation? Do they have a history of care under general anesthesia or being seen in the OR? And we want to know, when was the last visit when they were seen? Did everything get taken care of at that visit? Or were there outstanding treatment needs that still needed to be done? And if so, can we get a list of those? And knowing the last visit and whether they completed all treatment. So if they're coming to you and that's all been done, our hope is we can now be seeing the patients on kind of a preventive maintenance schedule. And how can we do that if they've traditionally received sedation or general anesthesia? We talked about some non-restrictive techniques, or what I call, touchy-feely, being nice and talking, communicating, and tell, show, do, and count and break, and other techniques last time. Today we're going to talk about, well, what do we do if we have to stabilize them to keep them safe? And there are a lot of different options for that. So we can talk about the fact we need a specific plan for each individual, and it's going to be individual based. One thing is not going to work for everyone. We want to start with the least restrictive methods each time that we're going to see somebody, that whatever's the least restrictive to accomplish what we're doing. Maybe for a prophy, we just need to keep their hands down, but maybe for restorative or operative surgery, we need a full body immobilization, such as what is traditionally called a papoose. We want to make sure we're recording all the information regarding how many people are going to be needed, how much time did it take, what is the specific behavior or the reason we're using this guidance? What is it we're managing? Is it because they're hitting, they're pushing, they're reaching into the treatment field? You want to make sure you include those details in your records. You want to make sure you know what has been tried in the past, what techniques we already use and failed, so that we can document that, yes, we now need to move on to the next level. And we also want to know, what is their overall behavior, medical and behavioral history, and how is that going to play into deciding on what the unique plan will be, and what is our action plan to decrease the use of stabilization as time goes on. We want to have a plan in place saying, oh, well, we need a full body now, then maybe next time we're going to release the legs and see how that goes. So we want to make sure we have a plan in place. So medical immobilization for protective stabilization can be mechanical, manual, or pharmacologic. We're limiting unfavorable actions or limiting movements that prevent or interfere with care. Many people do not consider pharmacologic interventions to be stabilization, but it is a form of full body stabilization. You're administering a drug that is affecting their entire um, system. So we must consider that as a protective stabilization, and we'll go into that more next time. So manual and mechanical. Immobilization is part or complete control of somebody's arms, legs, head, torso, whatever we need to stabilize. It's necessary to prevent injury to the individual themselves or injury to others, those performing care. It should only be used for the duration of the medical or dental appointment or the procedure. So you'll see on one side here, I've done full body wrap in the office, full body wrap at home in order to provide oral care. This is going to be a minute to 2 minutes of wrapping someone in a blanket to provide adequate oral care and then unwrapping them again. And you'll see we have the location part where they're seated with their head back, which we discussed before. This is a perfectly valid thing to recommend if you can teach individuals how to do this in a home setting, if that's the only way to keep their arms down and their body and everything safe, so you can provide adequate care. Because this is a medically necessary procedure that we're providing, and this need for care at home is just as important as administering food, administering medications, but it isn't always viewed that way. And we have to stress, hey, this is the safest way to be able to do this at home. Let's get you used to it. We want to make sure we understand this includes manual techniques, mechanical devices, use of a board, or whether we're using a sedative medication. So we always want to start with the least restrictive, I can't specify that enough, and utilize incremental applications moving up to the most restrictive. And in my lecture series here, drugs are considered the most restrictive that we can introduce because it will affect all the body systems and it will affect the patient long after they have left your office. One of the things about stabilization is with manual and mechanical stabilization, sure, maybe the person is upset. Are they upset because they're being stabilized, or are they upset because you're making them do something they don't want to do? But also, when we're finished and they're released from whatever stabilization we're using, they're back to baseline, or they should be back to baseline within a few minutes. And so we need to ask ourselves, is that going to be safer for the patient than leaving them on a medication that may cause them to have difficulty after the appointment when they're well out of your purview? Keep in mind, every state has different laws and restrictions regarding stabilization and such. And many times for medical providers and dental providers, we have an ability to do things that many times in a group home, it's considered abuse. So they won't assist you. They will say they can't do that at home. And many times it's a matter of getting the plan written, having it approved by their legal guardian, and then having it approved within the powers that be at the group facility so that these things can be put in place if it's the only way someone can be treated safely. So you do have to know what your state regulations are regarding stabilization in a medical setting. Remember, even though we're dental, we're also medical. And sometimes the Dental Practice Acts won't be very specific about it, but most medical practice acts will. So, limiting movements that prevent or interfere with care should include holds of short duration for safety. When we're holding the head, manually stabilizing the head, the joints, we can use joint stabilizers or full body stabilization. Here's a picture again of use of a full body immobilization for safety and stability at home. So, medical mobilization can be partial or complete control necessary for movement. So, any manual method, physical, what is restraint? First off, let's define it. So, it's any manual method, physical or mechanical device, material or equipment that immobilizes or reduces the ability of a patient to move his or her arms, legs, body, or hands freely, head freely. Any of these techniques must be reviewed as safety measures and never as punishment. We always want to say we're using a safety holder, a safety wrap, something to keep you safe. You know how you sometimes reach up? We're going to put our safety arms on. You know how you close down? We're going to put a safety holder in so you won't bite something and hurt yourself. Drugs or medications, when they are used to restrict a patient's behavior or their freedom of movement, and is not a standard treatment or dosage normally given for the patient's condition, is also considered a restraint. So giving somebody the Valium, giving somebody the Xanax, the triazolam, that is a restraint if it is not just they already take risperidone, we're going to adjust when they take it and try to maximize what they're already taking and hit it at peak time for treatment. So that's the biggest difference is, are you introducing something new or increasing something to manage their behavior or restrict their freedom of movement versus, yeah, they take this all the time because they have to. What's not a restraint? A restraint does not include devices like orthopedically prescribed devices, surgical dressings or bandages, protective helmets, or other methods that involve the physical holding of a patient for the purpose of conducting routine examinations or tests, or to protect the patient from falling out of bed, or to permit the patient to participate in activities without the risk of physical harm. So this does not include a physical escort. For example, if somebody is falling from a chair or a wheelchair, they may have a safety belt. That is not considered a restraint because it is for the purpose of protecting them from falling so they can participate in activities. A mouth prop to conduct dental examination is not a restraint because it is allowing us to safely protect the patient in order to do a routine physical examination. You can see here, this looks as though this person has been injured. This is because they have to routinely kind of grab her arms if she's reaching for things she's not supposed to, and because of her blood thinner, she bruises easily. But when you see something like this, of course, your first thought is, oh, what's going on? Why is she so bruised up? Are they hurting her? This is from the fact that she is unsafe and has to be, constantly redirect. Here we have a seat belt. Here we have the mouth prop. These are all standard and not considered a restraint because we need it to conduct the exam. Keeping their head back and from moving is not a restraint necessarily if we're using it to complete the exam. It's only there during the time we're doing the exam, then we're letting go again. Now, again, in some instances, they may say, oh, that is considered a restraint. And I guess, you have to ask yourself, is this just a reminder not to come forward, or are we physically fighting against an equal and opposite motion? Right? So we're pushing as hard down as they're pushing up to keep them still, or are we just resting our hand to remind them, don't bring your head up off the chair? So we must explain in our informed consent. An informed consent is necessary anytime you're going to provide stabilization. And some states have very strict what needs to be in the informed consent. Some agencies have a whole legal counsel that needs to review your informed consent. But the key thing is it must be informed and it must come from the legal guardian. So you have to establish, first of all, that you are talking to and getting consent from the legal guardian. Don't fall into the mistake of the person who's there because they take care of them in the home. They think they can give permission. If they're not the legal guardian, they cannot give permission. And you must make sure you're dealing only with the legal guardian. You must explain in your consent why are you needing to stabilize the patient. You have to explain what's the least restrictive management method that you're going to use first, and that you will start with the least restrictive first, and then you may have to specify and add more modalities going up to all the way to full body stabilization. Our consent that we get from guardians who may not be able to be present gives us consent to go all the way to full body immobilization with the understanding that we will try least restrictive methods first. So we'll go from the least restrictive to the most, but because these individuals are hard to get a hold of, we get consent for the max and hope we don't have to use the max. You want to specify the amount of time that you are going to have the consent be valid for. Is it going to be valid for 6 months? Is it going to be valid for a year? How often will somebody be reviewing these plans and making sure they're being updated according to how the patient has adapted to care? We usually have ours be a year. You have to have a dated signature from the prescribing provider, the person who says, the person that needs the stabilization needs to be the person to write out, this is the stabilization that I need. Someone else not in the treatment can't tell me what's going to work for me when I need a patient to be stable to provide treatment. I need to be the person to request, I need this. You figure out a way to make it work if you have to go through, different plans and different, steps in order to get it approved. You want a dated signature from a legal guardian, preferably witnessed. Sometimes you can get phone consent Make sure that's also witnessed and well documented that you receive verbal consent to do whatever at the time. Nowadays, with all these, FaceTiming and being able to do video calls and stuff, sometimes you can show exactly what it is you're talking about by doing a call that way, especially if someone comes in and they need to be stabilized. You've got to do what you've got to do. You're going to get a hold of the person, say, hey, this is the only way we're going to get this done. So this is what I want to do. You can get it right on the video, get consent, get it witnessed, document it that you did get verbal consent from the legal guardian and it was witnessed. And that usually will take care of it for you. You want to make sure that you're specifying what modalities you're going to use and for how long. For example, you're going to stabilize their head throughout dental procedure with numerous breaks, meaning if I'm not doing anything in their mouth, I'm going to let go of their head. Now, sometimes it takes a lot to get someone stabilized in a papoose, so you may not have the luxury of releasing them and wrapping them and releasing them and wrapping them. So you want to say you don't anticipate the procedure is going to take longer than X amount of time. If you are going to be doing a lot of consent, it is helpful. First, let your malpractice carrier know and the insurance carriers know who are going to be reimbursing you. And that we'll get into that a little bit more about the reimbursement in our last lecture. But it doesn't hurt to have a legal counsel or a malpractice lawyer review your consent form to make sure it covers all your bases. And you should let your malpractice company know if you're going to be utilizing conscious sedation, stabilization, especially with the sedation of any form in your office. They need to know you're providing sedation because it changes your coverage. But it doesn't hurt to let them know I am going to be doing stabilization so they are aware in case an issue comes up in the future. Informed consent. You have to list the risks of not using the management technique versus the benefits of using the techniques. So here, some of the benefits are improved safety from injury due to inadvertent movement, ability to be able to see and access the area to be cared for, improved access, safety for the staff and the care providers, improved overall health due to the improved oral health. Risks, of course, are pain or infection secondary to unaddressed dental disease. If you don't treat the disease, and we talked before about, let them know cavities, perio are infections that are being treated. It's not just, well, it's just a cavity. Well, it's a chronic infection in the person's mouth that can cause a great amount of pain. Sometimes there can be discomfort or bruising from aggressive movements within the stabilizing modalities, and it might increase their agitation or aggression during the time that they're stabilized or for a short time afterwards. And I always find it helpful the next time the person comes in to ask the people that were with them after the appointment, did you have any problems after the appointment due to their stabilization while they were here? Perhaps they were fine when they left, and as soon as they got outside, they became overly aggressive or whatever because they were angry that you let us stabilize them or wrap them. And if that's the case, we need to take that into account. I find the best way if you're running into issues within an agency or something, I find that a direct conversation between the dentist and the guardian is usually the best way to ensure that the safety measures needed for proper care in the office and at home can be obtained. I find it's the best way to have pictures to ensure that you and others will be able to help the patient. Many guardians are surprised when they find out that the caregivers aren't holding their head still to brush their teeth, hold their head still for 20 seconds and brush their teeth and release at a time in order to brush their teeth. And they'll say, well, how are they doing it? And I'll say, they're not. That's the problem. I'm trying to get a plan in place saying they can hold their head still for 20-second intervals to brush their teeth. And, they'll look at you over the phone or however and say, well, of course, how else are they doing it? So you may be surprised when you do try to call to get consent for a plan that they're surprised that people aren't already doing it. They don't even consider it a restraint, but technically it may be. So we want to make sure that people understand restraint versus help. It's important for individuals to view the process as helpful. And the stabilization is going to be of short duration for the safety. Always stressify, we're only going to be doing this for this long to keep you safe. Even if it's to keep us safe, you want to find a way to word it so the individual is told they're being kept safe. And again, as I spoke about in my previous lecture, even those people that they tell you cannot understand because of their limited intellect or they can't respond, they're nonverbal. I don't care. I always communicate with the patient. I always try to look them in the eye, use a calm voice, and say, remember, this is our little mouth holder that we're going to just rest between your teeth so you won't bite on something that can hurt you on accident. You're saying, I know you wouldn't purposely try to bite us. We know that you wouldn't try to bite down on purpose. It's an accident. We get it. This is just to help you so that you can't hurt yourself. We're going to place it. We're going to count to 10. Then we're going to take it out again and we're going to practice that. Then when they're good with it, we're going to, put it in, introduce the mirror. It's safety, safety, safety. We're keeping you safe. We're going to introduce it a little bit at a time so you know what's going on. It can be utilized as part of the health plan at home. You just have to write it out appropriately. But make sure when you're trying to introduce, pull the person's lip out of the way using the classic fish hook, right? Like a fish, get your finger in there, move the cheek out of the way so you can get to the back teeth. Putting that in the plan of care, it needs to be, you want to write it as orders. If you just say it's a recommendation, you're less likely to get cooperation on the other end. Physician's orders need to be followed. Recommendations, well, we tried, didn't work. Offering to do a telehealth visit, showing them how to do the fish hooking if they don't quite understand, doing it on the patient, taking a picture, sending the picture back. This is what we're talking about because nowadays, everybody's got a cell phone. We can take pictures, we can email those pictures and say, look, this is what you need to be doing to take care of the person. And this is not a restraint. This is just a way to get their cheek out of the way so you can see what you're doing. You're probably hurting them more not doing this and jamming them with the toothbrush. So again, it's a helpful and we should not stress the restraint or restricting movement. Adding MIPS to the care plan. So, put a plan in after other techniques have failed. Continue to try other techniques before you implement the plan. You may need to have a behaviorist involved in the plan, especially if the person has issues with stabilization or oral combativeness, a history, something like that. You may need to have a behaviorist help put it into the plan, or you may need a behaviorist to put it into the plan in order for the group home or the facility or the agency they're living with in order for them to be able to execute the plan. You send the recommendations, the psychologist has to say, yep, it's okay. Then they finally do what you're asking them to do. You want to make sure these plans are being reevaluated on a regular basis. And of course, you always want to monitor breathing, agitation, color, temperature. You want to make sure that, nobody is starting to be overly restricted or somebody is getting overly upset, making sure they're staying comfortable. And very often, when you try to put these techniques into place and they say, well, can't you just give them a pill? You can't knock them out every time you're going to need to provide oral care at home. So coming up with a plan that's going to work is critical. And if that plan includes some type of stabilization, teaching those stabilizing techniques to the person providing care is also critical. And that's our job. That's on us. No one else is going to show them how to hold the head still and brush the teeth. No one else is going to say, why don't you sit them down with their head in your lap so you can cradle their head looking down and brushing their teeth instead of they're standing up and you're stabbing at them and everything else. Maybe you have to say, look, if you wrap them up in a blanket quickly for the 2 minutes while you brush one area at a time and then let them loose again, you're going to have more success than battling the arms and everything else at home. Who can provide stabilization? MIPS or stabilization, and this does not mean sedation. This is stabilization can be performed by healthcare providers, practitioners, medical dental staff, agency staff, a family care provider, a family member, a guardian, a friend. Anybody who's instructed can provide stabilization. This lady is just one of the many caregivers that he has, and she helps to keep him stable in his wheelchair while we're working because his hands tend to come up. And this guy, I often tell people when they're doing head stabilization, I say, whenever you're providing stabilization, it's equal and opposite. So if they're pushing this hard, you're pushing back that hard, right? It's equal and opposite pressure. And I say, some of these guys may weigh 70 pounds soaking wet, but they're practicing with weights, lifting their heads and getting those neck muscles nice and strong. So when they come to the dentist, you can barely keep their head still. So don't be fooled by size. So things you want to make sure you document. What modalities are you using? How long are you using it? What breaks were given? How many people were needed in order to implement what was going on? And how effective was the stabilization or the use of MIPS? Was it effective? Was it not? Do we need to change the plan or do we need a different plan? So those are all things we need to take into consideration. So safety, stabilization, and holds. Remember, we want to make sure that when we're holding hands or blocking hands, we are preventing grabbing, preventing blocking, keeping the head still. We can't hit a moving target. And holding or restraining the torso also prevents sudden movements that aids, in the mouth and allows time to see and treat. So don't be afraid to put these things in the plans. The key things to remember and for safe and effective stabilization is always put the pressure on the bony prominences, on the forehead, on the cheek, on the lower jaw, on the long bones. We don't want to be smushing our fingers in that fleshy part in the floor of the mouth and making the person feel as though we're choking. We want those fingers nice and secure on the mandible. We always pressure opposite direction to resistance from the person being cared for. If he tends to go to the right, I'm going to stop him from going to the right. And I'm going to use the same amount of pressure he gives me. If he's a head lifter, I'm pushing down. But if he's not lifting, I'm not going to be putting any pressure. But if he starts to lift, then I have to put pressure. The important thing is making sure the person doing the stabilization understands just because they let up or relax doesn't mean they aren't going to suddenly try to move their head. So you've got to be ready for it. We want to make sure that we are just preventing movements. We're not necessarily relocating the person. We can use our hands, our arms, shoulders, chest, whatever we need. Cradling somebody into your chest like so can be a very good way to stabilize someone. I kind of call this the noogie position because I'm getting behind, I'm getting them secure, with their head right in here. I've got my thumb on their chin, I've got my fingers on the bottom part of the mandible, I've got a nice stable base, and I'm getting in there, and my assistant's coming in with the prop and getting the mouth open, and I'm holding them nice and still, and I've got a nice secure fit around the person. It usually requires a couple of people for torso stabilization. A seated wrap can kind of be accomplished anywhere. You just want to make sure that you do not tip the person back much further than a 25-degree tip back, but this is simply getting behind the chair and with their arms crossed, you're reaching around and holding their arms so that they cannot come around. A skinny chair is the easiest way to do that, almost like a kitchen chair. I learned this technique because they were utilizing this technique to feed the person. And when the person said, do you want to see how we feed them? And they did this wrap. I said, oh my God. So I put in the order, utilize the same wrap that you utilize for feeding to provide oral care at home for 30-second intervals or 10-second intervals, whatever I put. And it worked like a charm, but no one had told me this is what they did at home. As soon as I knew this is what they did, because this person always wanted to come forward and put their head on you and get hugged, as soon as I knew this is what they did to feed the person, I did the same thing and we never had a problem again. So again, these are some of the questions you can always ask too. How do you manage to do X at home? Always make sure you're not compressing the chest. If you are providing torso stabilization, they have to be able to breathe freely, so don't be overly restrictive. Full body mobilization, I think I already mentioned, can be anywhere. It works great for people who like to be swaddled. It works great for people when they say they like a weighted blanket. They usually like that cuddling feeling, the weight on their shoulders, that swaddle feeling, that cuddled in feeling is often more relaxing than it is restrictive. And it's always good to ask, do they like being tucked in? If they like being tucked in, chances are they're going to like being wrapped. And as much as people insist that, oh, this is barbaric, a lot of people like it. They consider it, it's almost like a full body massage. We have students try it, and sometimes they have a hard time getting them back out of it because it's like, oh my God, this is great. Call me in an hour, you know? So you always want to be creative and think about what's available, what's familiar. If you've got x-ray aprons, you've got weighted blankets. So those are, think about the common items and what you already have. The use of sedative drugs with patients with special healthcare needs is rather cavalier at times. They're very often, it's common to give somebody a drug and say, well, can't you just give them some Ativan? Can't you just give them some Xanax? Can't you just give them a little something on the way there so that we don't have these problems? And they use these drugs for physical, behavioral, and emotional limitations that the patient may have. The goal of these past lectures has been to say, hopefully, you can see that there are other ways to limit unwanted movements, that we should try stabilization first, even though many people see stabilization as a restraint. We need to stress that pre-treatment drugs are also a form of restraint. Many people don't see it that way. And when you describe how it depresses the respiratory system, it depresses the cardiovascular system, it depresses the central nervous system, then they start seeing, oh, you're right. And this is going to last for hours. How are you going to take care of them afterwards, right? So sometimes it's very important for them to understand that these are also restraints and that a physical stabilization, a mechanical stabilization is much less restrictive than a drug. It may or may not improve their ability to cooperate. Sometimes, we have to ask ourselves, why are they being resistant? Is it fear? Is it pain? Is it frustration? Some of those things we talked about last time. Is it habitual? Can we reassess and try other things? Because not all treatment environments are the same. So oftentimes they'll come in and say, you're not going to be able to get anything done if you don't knock them out. I'm thinking, sure, just watch me. Challenge accepted. We're going to try all of our tricks. We're going to try everything that we normally do, and you might be surprised at how much we actually can accomplish. In some instances, in order to provide safe and effective care for our patients, we need to stabilize the patient to prevent involuntary or voluntary movements. This is provided as a safety measure, never as a punishment. By stabilizing the patient, we can often avoid sedation and general anesthesia and still provide safe and effective care. Our patient is going to utilize a full body immobilization today. You need to have the board set up before the patient arrives. There are different names for it. We like to call it our full body immobilization. You want to make sure that the wrap you are using will come over the patient's shoulders. If you don't secure the shoulders, they are generally able to wiggle up and out. So you want to make sure that you get the shoulders secured. Most wraps will also come with a way to secure the wrist by placing the wrap around the wrist, and it also attaches to the wrap itself. You want to make sure that they cannot pull their arms out. When you have the arm inside the wrap, you want to make sure to have the hands flat to make sure the arm is safe. Now, somebody who has permanent contractures, you may end up having their hands up and over, and that's perfectly fine. Once we go to do the wrap, it comes up and over, and we've secured the top portion of the torso. And then again, up and over. And with this wrap, which is the Rainbow Wrap system from the Specialized Care Company, there is a break in the wrap, so if we need to have a pulse oximeter or something similar, we have the ability to use that. If somebody still needs their legs stabilized or their knees stabilized, you can add a wider strap that will then go around and secure the lower half. Once your patient is appropriately secured to the full body immobilization system, you want to make sure that this is also attached to the chair, so if the patient starts to move, they're not able to rock and pitch themselves off. So again, you utilize a safety strap to make sure the patient is going to remain on the chair. The stabilization system also comes with a hinged fashion if the patient needs to remain seated, and you can utilize the same wrapping system. Once you're finished, simply release the patient.
If you're wondering about
any injuries, bruises, or abrasions.
If you're wondering about the best thing to start with, I would start with a hinged board.
Sometimes we have to stabilize a person's arms or legs to keep them safe and to be able to provide safe and effective care. If you have a patient who tends to be reaching or grabbing into the field of operation, that obviously can be dangerous for the patient. We can eliminate the ability of that patient to bend their arms into the field of operation by simply using one of these elbow stabilizers. They're also sometimes called no-no arms. This will wrap around and remove that plane of motion so they cannot, which will also help keep them safe and their arms down and easier to help hold that arm, hold the hand, and keep the patient safe. If you also need to eliminate the other planes of motion, one easy way to do that is to then use the elbow stabilizer and add a belt that can slide behind. And then you come across, and then you've prevented all the planes of motion for the arms. If you also need to stabilize the legs, somebody's kicking, bending, or has an inability to keep their legs still and it's a problem, we have the same stabilizer but for the knee. It's going to be a larger size, and again, you're going to place it over the joint. Once attached, you now remove the bending and that plane of motion. Should you need to simply prevent a side-to-side motion, you can also then use one of the wider belts, and like so. Obviously, our patient is able to move side and slide these in, but normally, if you know you're going to need them, you would want to have them in place before you start.
And that's that. I hope you caught the fact that, these are if necessary, right? The whole idea is adapt to the patient's needs. If you have a patient that has to sit and bend their legs, if their legs aren't getting in your way, then let them. I sometimes have parents constantly straightening the legs. I'm like, it's not in our way. If they want to bend their legs because they're more comfortable, that's fine. Let them. It's not an issue. So sometimes that's a key thing to remind people. The other is, these stabilizations aren't only because of behavioral issues. It can be because of a medical inability. If they have spastic cerebral palsy or some other condition that causes inadvertent muscle spasms, protecting them from those spasms is very important. If they spastically close down and you're not protecting them with a mouth prop, you can cause them a lot of damage. And individuals who do suddenly reach out are just as scared of hurting you as you may be of them becoming hurt or them hurting you. They're just as scared. So, saying, do you want me to do something to help keep your arms from reaching up or coming up? Very often they'll say yes. So you need to keep in mind that these stabilization items aren't only because of behavioral issues, they're sometimes medically necessary simply because the person can't sit still and they don't want to be drugged either.
Yes. Hi, Sam. This is Sarah. Eileen and I are here from Samuel's. Eileen just doesn't have her microphone on her computer, but we use, the device, the nomenclature that we have has changed a lot. We used to call it a papoose, and then it was medical stabilization. We now say positioning device. So we have a hinged one, which allows patients to be a little more upright. And just like you were stating before, like you don't have to have your legs straight when you can cross them. We kind of say, oh, it's like a yogi here. Like we kind of, the attitude that you have around it is also helpful for parents or staff or guardians and the patient too.
Mm-hmm. Absolutely. And I started to say, let's say your funds are limited. I would recommend starting with a hinge board because a hinge board can be made flat, but a flat board cannot be made to sit upright. So start with
Right.
one that's hinged if you're going to be limited in your funds. That's the best way to start. And then the size of the wraps is very important. They've got to be able to come over the shoulders and they have to be able to be relatively snug.